Now we'll move to our next talk, which will be ACR CT Dose Index Registry, how it might affect your site, and that will be by Dr. McNitt-Gray.
Okay, I'm just going to point out that of the first, how many speakers have we had? 5? I'm the only one who adhered to the dress code. Okay, just want to mention that. Oh, violated that. Okay, making me look bad. Okay, so let's talk about the, here's my disclosures again. None of them involve the ACR Dose Index Registry, by the way. So what I'm going to do is describe the goals of the DIR, how it operates, what kind of feedback a site can get, and describe how these reports might be used by a site to audit its own practice. I'll talk about the limitations of what it does, but I'll tell you a couple things that we've done at our institution. Okay. The Dose Index Registry goes back to a very fundamental question, and I'm not sure who asked it first, but I've heard Rick Morin, as sort of the director of the DIR, asked this question. So I assume it came from him or somebody that he stole the question. What's the national average of radiation administered by imaging facilities for a CT of the head? What's our average dose for a CT of the head across the United States? And we didn't have a mechanism to answer that question. So that's not the only thing that the DIR does, but it started with that kind of simple thought. Okay. The DIR is one component of the National Radiology Data Registry. There are others. It collects and compares dose index information. I just want to make sure we understand dose index information across facilities, and it uses standard methods of data collection. There's the DICOM Radiation Dose Structured Report, and there's the IHE Radiation Exposure Monitoring Profile. As some of you know, I think we had an example of it earlier, but I can't remember. So some scanners don't put out, they need a software upgrade to get the radiation dose structured report from the DICOM form, but instead they put out the patient protocol pages, and those can also be sent to the Dose Index Registry, and they can be used with optical character recognition techniques as well. So a lot of the data information can be extracted from there. Its goal was to establish national benchmarks and practice patterns in some of those dose indices. And I'm going to go through this again, but its goal was not to track individual patient doses. Okay? That's not the goal. So that's not what it does. And we'll talk about those limitations in a minute, but that wasn't its original design. Okay, so how does it work? The scanner sends information, either a DICOM structured dose report or a patient protocol page to a external machine. We have a server on site. They call it Triad. That anonymizes that report, either the DICOM or other information, and puts it into the Dose Index Registry database. At the database, they collect this from a number of sites. I'll show you how many in a minute. And that which is part of that National Radiologic Dose Data Registry. And then you get feedback reports from the Dose Index Registry. And I'll show you some examples of that and how we've looked at those and used them in our own practice. So it's reasonably painless. You do need either real or virtual server on site, but the rest is pretty straightforward to set up. There are some specific steps that you have to go through. You have to sign a participation agreement and complete a registration form. You have to do the physical setup and start sending the data, and then you can obtain reports. There is a fee. It's not free, but it is a reasonable fee, I think. Let's see. This is the number of sites that are active or registered within the Dose Index Registry as of recently. I think December, the end of December. Is that right? Okay. So on the order of, I think that number is about 295 sites participating, and about double that registered and just not sending data yet. And so you can see that it's grown. They've been going on this for almost 2 years now. In terms of the exams, you can see in green the exams here, and the blue is the actual number of scans where the exam may consist of multiple exams. Sorry, I got that wrong. Exams may consist of a number of scans. We might call them series. So on the order of, I can't read that number, but anyway, it's on the order of, I think, 200,000, something like that. It's quite a significant database now. The distribution is significant all across the United States. I think there are some participants from overseas as well. Okay, but it's quite a good geographic distribution, except, okay, Arizona, come on. We got to get with that here. Just a couple of us here. Okay. What about the reports? So we've been sending data to the Dose Index Registry, and I'll show you the concept of the reports, and I'll show you some examples. Each quarter, they give out reports back to the sites. The report shows information regarding dose indices again, the CTDI-vol, the DLP, and the SSDE that Keith Strauss described. But that's only given if the CT radiographs are sent, because they're doing a calculation from that CT projection radiograph. Okay. Those of you with Radiometrics, you can have your software export data to the Dose Index Registry, and that information is also exported. I think they're sending the size and the SSDE information, but don't quote me on that. I'm sure somebody else can give a more informed answer to that. Not only does the report give you information back about how your site is doing, but it does some comparisons between each site and the entire Dose Index Registry, as well as its peers, as well as your peers. As defined by your geographic region, we're considered West. Demographic, we're considered metropolitan. And type of facility, we're considered academic. So we get compared to academic nationally, metropolitan nationally, and within the West region. Okay, so here is an example of the summary. Okay, so here's the executive summary. This is our facility number. The CTDI-vol per scan, not per exam, but per scan. And you can see that there are, let's see, this, I forget what RPID. RPID is a radio, I forget. There we go, thank you. Radlex Playbook ID. I was going to get to that part, but I couldn't remember the acronym. Thank you, Mark. So here are some generic descriptions. This may not be the description that you have at your facility, but we'll talk more about protocol naming in a second. There is a mapping from your facility's protocol names to these more generic names. The numbers here are, here's your 25th median and 75th centile of the data that you sent for this protocol. And here it is. Here are those numbers across all Dose Index Registry sites, and then your comparisons to metropolitan and West and academic. And you have this for all these different exam types. Okay, so it's really quite a significant amount of data coming back to you, and a lot of places to do comparisons. So it's a lot coming at you. This is the executive summary. Let's see what else there is. So the naming of the protocols, that RPID, that Playbook's ID, the ACR recognized early on this was a difficult issue. In the routine head, I dare you, go look at your institution and see what names you have. Okay, from routine brain to routine head, adult head, standard head, 64 slice head, or Dr. So-and-so's head, right? I'm sure you've seen some of those, right? Okay. So the ACR approach has been twofold. They've tried to adopt the terminology and classification from that Radlex Playbook. That's where that RPID comes from. That radiology lexicon from RSNA. And they've employed a software tool to have the sites map their own protocol names to these standard protocol names. It can be a little tedious at first, and I still don't know how to map our research protocols, so we've left some of those out. And but for your routine or what's routine at an academic medical center, right? We hardly do anything routine, but we have some sort of standard names, and we have some exotic names that may be just peculiar to us. But we try to map those as much as possible. So there's lots of subtleties here, and not to mention the use of contrast. Protocols are segregated by their use of contrast or not. So, for example, there's a CT abdomen pelvis with contrast, there's a CT abdomen with contrast, and a CT chest abdomen pelvis with contrast, as well as their corollaries without contrast. There's a CT abdomen and a CT abdomen pelvis without and with. So there's lots of flavors here to try to put your protocol into. And it's a struggle. I acknowledge that. Everybody acknowledges that, but at least it's a path to get some harmonization here. Okay. And you don't have to change your protocol names at your site. It's just a mapping of your protocol name to a more standardized protocol name. There's some other data they give you as well. They give a box and whiskers plot. And those that not used to statistics, you see this Here's the box. The box represents the 25th and 75th centile. The median is the line in the middle of the box. And the whisker is the minimum observation and the maximum observation. So you can see the outliers pretty well. And then you get a red line to tell you what your median value was. Okay, so you get to compare your median to everybody else's. Okay, so here we go. Don't yell at me one way or another, okay? It takes a little nerve for our radiologists to agree to this, and maybe some of them haven't actually already agreed. So don't tell them I'm having this data up here. Okay, so, here we go. So here's our CT head brain, that's the generic name, without IV contrast. And now it's CTTI vol per scan, not per exam, because exam may involve multiple scans, but this is per scan. And here's the DIR, here's the metropolitan, here's the West, here's the academic, here's the number of facilities, here's the mean, standard deviation, all that. All those values are in table form as well as in this box and whiskers plot. The box and whiskers plot tells you graphically where you stand. Here's where we are. Here's the median across the DIR, the metropolitans, West, and academic. And there's the 25th and 75th centiles, and there's the high values. And I put in there, this doesn't come with the report, I put on there, there's the ACR CT accreditation program reference level, 75 milligrade for an adult head. Okay? So, we're not using iterative reconstruction on our heads. We've just got some very aggressive neuroradiologists. And so our mean value is somewhere down here. I think that says, where is it? Oh, I can't remember now. Anyway, we're down in the 30s. Down here. Okay, that's the one. See, notice I showed you that one first, so it will warm me up to some other ones. Okay, but that's the kind of data that we can go. In fact, I often use this, okay, I'll tell you about that in a second. Okay. All right, here it is in terms of dose length product. You get the same kind of information now with a different index. Okay, so what about actions? What did we do with this data? Okay. So I showed this data to the neuro section as we were going through their protocols, and I said, we're pretty low on this. And I said, do you think the image quality is okay, or are we pressing the limits here? And there's a little bit of discrepancy within the section, but I pointed out that they could increase the dose. Sorry, I hope I'm maybe the only physicist saying to the radiologist, you sure you don't want to increase the dose? But okay, I'm saying, okay, in certain situations. I said, if the image quality is okay, then stand pat. But, you could increase the dose and still be well below the national average. Okay? And well below the ACR accreditation level. Their response was, hey, they think the image quality is diagnostic and there's no need to change our protocol settings. Okay, we've had the conversation. Okay? I'm not going to overrule them. I'm not going to say, come on, really? You're not diagnostic. That's for them to decide. They're happy. And they've been doing this for a long time. Our doses have been low like this for 4 or 5, maybe longer years. So they're pretty comfortable. So, okay, we used the tool. We had the conversation. Decision was stay where we are. Okay, here's some other examples. CT abdomen pelvis with contrast. Again, here's the number of facilities, the mean value. This value is, let's see, about 17 is the mean across the sites, across the DIR. I put in again the limit for the dose for the CT accreditation program at 25 milligray. Here's the box and whiskers across the DIR. Here's metropolitan West, and we're a little above average here, a little above average compared to academics. I forget what our number is. I think that says 17. Thank you. Okay, so we're a little above that. I think the mean for academics was right, so it's about 13 there, 14. Okay, so we're a little high there. Okay. And again, this is per scan, not per exam. So this doesn't address the issue that Don brought up a minute ago about multiple phases and whether you need to do them and all that. This is just when you do a abdomen pelvis with IV contrast single scan. Okay? You want me to point out the max?
No, but what they're showing you is the max CTI vol within of all scans in your exam, right?
Good question. You're saying that, the question wasn't a question, it was a statement from Dr. Cody telling me that I should say that what that number refers to is, she said it's the maximum, if you do multiple phases, it's reporting the maximum of those phases. I think that might be right, but I'd have to check and make sure. Or Penny, do you know? I couldn't hear what you said, but I'm going to say, okay, good. Yeah, okay, of course she is. Okay, good. Okay, well, we knew where that was headed way before we even, okay, good. All right, so, all right, here's the same thing with DLP. Again, we're a little high. Okay, so we can have this conversation with our body section and talk to them about this as well. But remember, this may be averaged across a number of protocols that we threw into that one definition. Okay, chest. Here's the chest without IV contrast. We're noticeably above the average here. Okay, again, our number is somewhere in the 20, is it 22? I can't read that. Huh? 20? You can see that. Oh, good. Okay. All right, and whereas the mean values here are down in the 10s and 11, 12, 13. Okay, so what do? We have a sit down with the chest section and say, what do we want to do about this? So we looked at our distributions. Well, this also comes in the data summary reports that come, not just in one value, but you can look at the distribution. So here's mean CTDI. This is for our site, and this is across all DIR sites. So you can see our distribution compared to others. Okay, and you get the same thing. You can do it now with DLP. That looks pretty consistent with the CTDI of all. Okay, so what do? We show it to the chest section, and we sit down, we have the conversation. And we ask them the same question. Image quality okay? Or could they tolerate more noise by reducing this, okay? We're not trying to embarrass anybody. We're not trying to say, hey, guys, we're way over everybody else. We're just asking the question, should we be reducing our doses? Let's look at these protocols, and should we be able to bring them down? Their response was, again, the image quality was diagnostic, and they didn't think they could go lower, and they thought the main driver of this was our diffuse lung disease population. We have a large population of diffuse lung disease patients, and they did not feel comfortable going lower in dose on those patients. So we looked at it protocol by protocol, but all those numbers are lumped in here as well. So anyway, again, I'm not sure this is a good example. We've had 2 conversations and no change, but at least we're having the conversation. Okay, good. All right. You can get these in tabular form with additional hints. They'll give you some information about where you're above the 75th centile, where you're below the 25th centile, things like that, and where you're right in the middle. So that comes in a tabular form as well to sort of highlight protocols that you should consider having these discussions with. Okay. Pediatric reports. They started to tailor these as well by age groups and by protocols so that you can do your CT abdomen pelvis with IV contrast by very discrete age groups, 0 to 2, 3 to 6, 7 to 10, 11 to 14, 15 to 18. And you can look at your performance values there, again, your comparisons, and across different protocols. So a very detailed breakdown and not just a global summary. Again, looking for places where you can have conversations with your sections about where you might want to look for places to reduce dose. We're pretty aggressive with our pediatric doses, so we've been having an ongoing conversation for years with our ped section. Okay, so the DIR is really a very good tool for determining where you stand, and it's very useful for reviewing protocols with radiologists, even if they push back and say, no, we're good. At least you're having the conversation with them and given some data to work with. So you might expect some varying responses, including, wow, our doses are really high. Or, wow, look at that, hooray, you deserve a raise. It could happen. Or I told you our dose levels were just fine. Okay, that's going to happen too. Or everyone else is just using too much or too little, fill in the blank, dose. Okay, we're doing fine. So, but at least you get to look at what other sites are doing across different categories and have the conversation. You can expect a range of reactions when you use these data mining or comparisons tools like the DIR. There's always a fear. Before people see the numbers, there's always a fear that their doses are too high. And the natural reaction is to say, no, I don't want to know. Okay, I'm sure we're doing great. I don't want to look at the data. Okay, even if you don't look that bad when you see. So one site that we had some discussions with reported a lot of initial resistance and fear, and they said, this is a paraphrase, of course. Our doses will be high, and we're going to be vilified for it. Okay, everyone's going to point to us, and our patients will think we don't care, and our colleagues are going to think we're a dose-hungry institution, et cetera, et cetera. But once they got involved and got the feedback, they found they were right in the middle of the interquartile range, and they sighed a great sigh of relief. And now they look forward to the reports, affirming their position squarely right in the middle, or sometimes maybe a little bit lower. So again, sometimes no changes are made, but the comfort level, at least you know where they stand, at least they know where they stand, and their comfort level raises about being able to modify protocols or at least have these kind of conversations. Okay, here are some other tools. I know I'm between us and lunch, right? Oh, I still got time. Okay. Some other reports that you can see, and some things that you can do to track. And I will show you one thing that we actually did take on board and have some conversations with. So there's a summary of the data submitted, some dose information by exam, and a summary of irradiation events. So you get this executive summary, and then if you really want to drill down, there are some nice tools that you can take advantage of. So here's some dose information by exam. This is on the Dose Index Registry website. You click on this, and you get the facility, and you can put in a date range, and then you get you get a report that you can then export to Excel, and then you can sort. So I did that with our data, and I found, so it's just the study description, the institution, our scanner, and the total CTDI vol and the total DLP. I sorted that so that I could see what our highest values were. Okay? Don't panic, okay? We know what's going on. That's what we're using this for, to drill down and say, wow, really? Almost 1,000 milligray? How did we do that? And then we can find the date and time. Okay. To do a more detailed look, you can actually go to a summary of irradiation events and dig into those numbers a little bit further. I did this. I found the date from the previous one, and then I put that into this query. And so now I can dig a little further and find out, for that particular exam, some of this. So I'm sorry, these are all extracted from DICOM headers. So some of this isn't normal terminology that we see at the user interface or that we use in everyday language, but that head constant angle acquisition, that's the SCOUT. Sorry, topogram. Sorry, yes, topogram, good. Okay. A head sequence, so our normal perfusion protocol is to do a non-contrast head first, okay? And then we'll do a head stationary acquisition. That's actually the perfusion exam, okay? So our perfusion exams are about 280, 300 milligray, and you can see it's a very low dose length product because it's only covering a couple of centimeters. After that, we'll do, this is actually a timing run, and this is another, this is the pre-contrast timing run. Let's see if it's not there. Okay. If you were looking at a Siemens dose report, it would tell you this would be the monitoring study, the pre-monitoring, and this would be the post-monitoring study. Okay, so this is that acquisition for bolus tracking that we do, first before and then after. Okay. Then we've got another pre and post. I'm not sure why we did it twice, but we did it twice. And then we do a helical acquisition, and then we did another perfusion exam. Okay. So some patients get this. It's possible for a couple different reasons. You can have a conversation and go back and say, really? Did we need 2 perfusion exams on this patient? I don't know if you've ever heard of this before, but sometimes we do this with and without an agent called Diamox, which gives them some, what's the word I'm looking for? It's the opposite of contraction. It's a dilation, thank you. It's the dye. It's a dilation agent, right? So we might look at this patient before we give the dilation agent and after we look at the dilation agent. It happens. Not very common, but it happens. Or the patient could have moved during the perfusion exam, screwing up all the perfusion calculations. So we had to do it again. So what the Dose Index Registry does is it adds all these numbers up. So that's how we got up to that 900. It adds them all up. Okay? So that is a little bit... we've talked with the folks about that. It's just one of those caveats you should know when they do this, even especially when you get it by exam. Okay? All right. Let's see. Here was an example of a diffuse lung disease case where we had, I was wondering what that was, because I went down to the CTDI vol and it said 0, but we still had a DLP. And I thought, really? We gave an exam with 0 dose? That's awesome. Okay, we should do that in everybody, right? Well, it was just it's a round-off error. It was just a very, very, very low-dose scan done in flash mode. And then we did a regular acquisition, and then we did another very low-dose exam there as well. Okay, so those numbers actually are reasonably true, even though 0 looks a little funny. Okay. And you can go back and look at those in the protocol page. Okay, so we actually looked at this data. I didn't show you a good example here, but we looked at reports like this, and we found that sometimes, because the values are added up, that one of the biggest contributors to those dose values was from our timing bolus, where we did the pre-contrast and the post-contrast. That was actually jumping up quite a bit. Now, it's a limited study. It's a small DLP value, but it can be a high CTDI vol value because it adds up every time you do a rotation. So if you're doing 6 rotations, you get 6 times the number that you would get for 1. And if you do 20 rotations, you get 20 times. So even though we're doing reasonably low dose on our timing runs, sometimes we were doing a lot of them. So we just made an inquiry and said, hey, let's reinforce with the text to try and keep those doses as low as possible, but still good enough to get the desired result. That is, good timing of the post-contrast series. So we just reinforced with them that we don't want to just let this run forever, that we really wanted to limit that as much as possible. Had to do with setting the thresholds for contrast enhancement, as well as what to do with patients with poor circulation. That's often a cause of these, right? You're sitting there waiting for the contrast to come up to a certain threshold, and it's going, but it's going really slow because of that poor circulation. That translates into a high CTDI vol value. Sometimes you just can't get around that. Or, you can see whether or not you can vary the threshold and say, well, maybe we can go with a lower threshold and not have to wait so long. So we've had at least part of that conversation. Okay. Let's talk about some of the limitations. The DIR cannot provide dose information for an individual or an individual patient's scan. It's all anonymized at the site, right? So they don't get patient information sent to them. They make up their own IDs. So it's not meant for tracking patient dose over time. You're going to have to look to other tools for that. All data was anonymized originally to prevent liability issues. In case they saw these high doses, they didn't want to be in a position of having to go back to the sites. So we've discussed with them the possibility of sort of reversing mapping tables so that they anonymize. They could get us a value, and that we could go back and map back to identify our patient scan. That's under consideration. So it may be possible in the future, but it's not something they do right now. Other tools such as Radiometrics, exposure house tools that allow a more detailed auditing of local scans. And it wasn't designed to just do a dose index registry. That was more in the design of those kind of tools. So that may be something you can do locally a little better. Just to summarize, the DIR is an excellent resource for determining local and national averages. It lets us see how we're doing as a group, or as grouped by either kind of practice or locale. We can break that down by the type of practice, and allow us to see sites where they stand in comparison to others, and at least allows us to have that conversation. It's an excellent tool at identifying where the efforts should be concentrated when considering dose reduction and protocol modification efforts. It can be supplemented. It doesn't do everything. It can be supplemented with other tools to assist with local auditing of doses and identification of individual cases where exposure may be higher than desired, or maybe an unusual exposure. Okay, some of the future work has to do with continuing the effort to standardize protocol naming to really allow those apples-to-apples comparisons, methods to separate out those dose values from the timing runs. They can be a significant contributor, but I think that they should be segregated out. So because just adding them up to the conventional doses, the doses from the other parts of the exam may not make all that sense. It's not easily identified in all scanners, and so there are different naming and reporting conventions of that across the manufacturer. So there's a little bit of work to do there. I think that's it. Okay, thank you. We have time for some questions before we break for lunch? Okay.
I just wanted to add, I think your comment about not being afraid of using the dose index registry is really important, and institutions that aren't involved should consider it because it is an excellent quality and safety tool. And even if you're afraid that your doses are high, one thing we were able to do at my institution is we said, okay, our doses are high on some of these. They're at the diagnostic level and quality that our radiologists feel comfortable with. We're able to take that data to hospital administration and say, look, we are higher than the average. Our radiologists don't want to go any lower. We need funds to get better equipment and new tools to be able to be more in line with what comparable institutions are doing. So I think even if you are afraid that your levels are high, at first it's important to have the information and have the discussion, but it can be used to help you move lower.
I appreciate that comment. I wasn't thinking about the strategic and financial aspects of this, but okay, good. I like that.
Yeah, my question is just a curiosity. Is there any data for different CT manufacturer, different model involved? Those statistics in the report?
I don't think, I'd have to think about that, or maybe Penny can jump up and answer as well. The question is there different data by manufacturers and model? I don't think so, but I can't swear to that. Again, on some of the data that's provided to you, you might be able to sort that out in the tables that are given back to you. But I'm pretty sure the dose index registry doesn't do that reporting back now. But there may be data that you can do, but only locally, not globally.
And also in the future, do you think we need to consider size-specific correction?
Sorry about that. I meant to mention that. I think I did, but maybe I should have emphasized that more. The dose index registry is set up to do size-specific dose estimates. We were not sending them CT radiographs, so we were not getting SSDE values back at UCLA. We're going to correct that shortly. But sites that do send them CT radiographs, and they need the actual radiograph sent to them, which is anonymized, of course, but from that they do a calculation on size, and then they can calculate the SSDE. So they do provide those values as well.
Thank you.
Okay. I'm going to go back to Jessica.
So we're all aware that the ACR has a limited set of reference values for us to use, and we've heard that a lot of this data is going to be compiled to help establish reference values for other exam types. Is there any timeline on when that's going to happen? Do you know?
No timeline.
And if you're not participating in the dose index registry but would like to see some of these national averages, is that published anywhere or going to be public in any way? No? Nobody knows?
Okay, let's put it this way. There are presentations, and I'm sure there will be publications. I'm sure those values will be published, but I'll let Penny answer that question about how it'll be distributed.
I just wanted to mention a couple of things regarding reference levels. There is a new guideline coming out, hopefully if it passes the council this year, on reference levels for diagnostic imaging. It's going to be primarily based on the NCRP report document that came out last year. Once we get adequate information with SSDE, I think we'll be using that to refine the reference levels. And we are currently in process of writing some articles on this, which will be published. And I also do believe a general overview or the data is downloadable from our website. I'll check on that and get back to you. But
okay, good. I didn't know that. Okay.
If I could just put in a one-sentence plug, the NCRP just did issue a report on diagnostic reference levels that slightly expands on the ACR levels, and that team was led by Dr. Brink.
Right, fair point. And that data is not based on the values from the dose index registry, but certainly that information could inform the next generation of those.
So from a practical standpoint, one of the things you have to do if you're going to do this right is get every one of your protocols set up so that it will automatically send to wherever your ACR box is. This is not a painless thing. Mike said that setting this up is painless. It's not painless. But once it's done, it's done, and then it becomes brainless anyway. So it's initially there is a little bit of pain involved. But I also wanted to point out that, the Joint Commission came out with that Sentinel event publication a year or two ago, and it said you should know your reference values. This is a good way to find out what they are. Because if you're trying to write all this stuff down or dig through a bunch of patient reports, you're going to drive yourself crazy. So this is a good place to go for reference values at your own site. And then I also wanted to say and ask, how many folks are from Texas? Do you know there's some new rules on the books that are going to be in effect May 1 that have to do with reviewing your patient dose values, having a committee set up. They're kind of using the Joint Commission approach where it's all documentation based. You have to write how you're going to do this and then follow it. This is another place that you might be able to use this registry. Now, they want you to be able to track outliers, which you can't do directly here, but you might be able to trick yourself into doing it by doing just what Mike did, by following the outliers by date, time, and scanner number. So this might be useful for the folks who are in Texas who are going to have to deal with this pretty soon. And that's it.
And setting it up actually can be it is very scanner specific. It's very easy on some machines to just send the dose reports to another location. It's not easy to send the radiographs, but in other systems it can be easier in other fashions. So.
I have a question not related to the registry, but specifically, but your slide that showed the heads being very low in the CTGI. And my question is that we've had some problems with abdomens. Similarly, not quite that far below the reference level, but with the CNR ratios that the ACR requires, our doctors are comfortable with the noise level, but we've been having to go to them and say, listen, you've got to increase the protocol, the mass, or we've got to change something, and they're happy with the noise levels that they have. Have you had to address this with your heads being so low, or?
Okay, right. So you're mixing a couple things, but I'll address it anyway, I think.
Okay.
It's not have to do with the dose index registry. That has to do with ACR accreditation.
Correct.
Okay.
I was just looking at. I just saw the low heads and was curious.
Believe it or not, at those doses we meet the ACR CNR criteria.
Okay.
So, and I will. Can I do this? I can do this, right? Okay. So for the ACR accreditation program, we've revisited the PEDS abdomen and PEDS head CNR values, and those will be lowered. Okay? I'm not sure if I'm allowed to say what they're going to be yet, but they will be lowered because we also heard from a number of people that they were having to bump up their protocols to meet that CNR ratio, and we didn't like that at all. And that's so those values will be lowered. You can go higher than that. That's okay if that's where people are comfortable, but we wanted people who were going to be aggressive to be able to say, okay, we can still pass accreditation at a lower CNR. So I don't know if I hope that answers your question.
No, it does. Yes,
okay.
Thank you.
My question actually comes from listening to all the questions, comments that we have, issues whether this data will be public, whether there will be publications. I've heard NCRP, I've heard Texas and regulations. So my question is, we have almost 500 institutes in the dose index registry, and I've heard few comments about use of radiometrics to kind of transport the data. How many sites out of these 500 are using radiometrics and how many are not? Because it's a tried server, if I'm guessing. And I'm coming to the specific question here is we worked with radiometrics and we realized that it was duplicating the chest and the abdomen doses based on the dose page. So now if we are trying to go public with this information, we get double the doses. Radiometrics has solved that problem that it can kind of divide the doses from the dose page. But is TRIAD able to do that, and are we looking into that we actually getting and what we're reporting is the same, just to make sure that we're not duplicating our doses and making it public?
Yeah, okay. So that's a great question, and I don't know the answer to your question about, number one, how many sites are doing it through radiometrics, or maybe there are other tools out there that also let them export dose data to the DIR. I don't know. We could probably have a little conversation with Penny or send an email to Laura Combs and get some of that information. And I'm not aware, but not surprised by the double reporting. For those of you that don't know, Diana asked, okay, you asked how many people from Texas. How many of you from California? Okay. So we've had to address this issue too, right? Because we are required, as of July 1st of 2012, last year, so we've been doing it for 9 months, we have to put the CTDI and DLP in the radiology report. Okay? And part of the question was, all right, we're an academic institution. Our chest reads this, our abdomen section reads this, and our, whatever. So who puts the CTDI in their report? How do we do that? So I presume there is some double reporting going on out there as well. But we're not summing those and saying the total was this. In fact, the state has been very flexible in how we actually address and do the reporting. But so double reporting of chest and abdomen doesn't surprise me at all, but I don't know how big an issue that is. I will say one other thing, that one thing that we have thought about and don't know the answer to is there is no DICOM field that has a checkbox that says, I used iterative reconstruction, right? So when I look at these numbers, and I can't tell who is using iterative and who isn't, right? Because we have distributions and there's going to be overlapping distributions. So we haven't figured that out. It would be great, but I don't think anybody's figured out how to identify a subgroup that says this is the group that's using iterative reconstruction and their range is such and such. So it's a great question, but I don't know of any answers, at least not at the moment.
Thank you very much, and thank you for all your questions also. We had some time before lunch, but I think we can head to lunch now, which will be in the same room where we had our breakfast. Thank you.